So I want to introduce our first speaker, Amale Lteif. Dr. Lteif is an endocrinologist at our IU affiliated Veteran Administrative Medical Center. She's been with IU for over 10 years, and she's really been able to develop an expertise in thyroid and bone disease as well as diabetes. So we're really grateful that she's here today. So thanks, Dr. Lteif.
Thank you. Thanks, Craig. Well, good morning. Today I will be talking about the endocrine consideration in autoimmune hepatitis. Endocrinology refers to the study of hormones and gland. And as you will see, there's might be some relevance to your disease of autoimmune hepatitis. Okay, here we go. Is this working? Craig? Oh, here we go. All right, so I will be mainly talking about thyroid dysfunction, both hyper and hypothyroidism, which could commonly occur in autoimmune hepatitis. We'll also discuss bone health. This is relevant because of use of corticosteroid, prednisone, that affects significantly your bone strength. We'll also touch base on regard to diabetes and glucose control in view of steroid use, and what we call adrenal insufficiency or cortisol deficiency after the steroids are stopped or tapered. So to set the stage, I would like to mention that among the most common associated extrahepatic, beyond the liver, disorders in autoimmune hepatitis are autoimmune thyroid disease, both hyperthyroidism, what we refer to as Graves' disease, or hypothyroidism, that we refer to as Hashimoto's disease. Also, type 1 diabetes is commonly associated with autoimmune hepatitis because type 1 diabetes is itself an autoimmune disorder that attacks the pancreas. Some of these associated diseases may predate or precede the development of liver disease, but they could also occur after or during the diagnosis of autoimmune hepatitis. The clinical expression of these associated diseases can be extremely variable and at times may be even occult and unrecognized unless specifically sought. Graves' disease, bulging eyes, goiter. Goiter basically refers to the presence of an enlargement of your thyroid gland, which is the gland that sits here in the anterior neck area next to the trachea. It can be enlarged diffusely or on one side more than the other. So typically when you see a goiter, you should think about thyroid disease. And in the setting of an autoimmune disease like autoimmune hepatitis, we think also about Graves', especially if somebody presenting with hyperthyroid symptoms that I will describe in a second. So hyperthyroidism is like a conglomeration of various symptoms. Typically, people who are hyperthyroid are heat intolerant. Like, they feel hot where everybody's still feeling comfortable or cold. Anxiety and insomnia is one of the symptoms. The hair gets finer and more straight. The eyes start bulging because actually there's an autoimmune process that affects the eye muscles. The face is flushed, there's excessive sweating, there is also tachycardia or palpitation, your heart rate goes high, blood pressure may be also elevated, there might be some breast enlargement in hyperthyroidism. Bowel movement become way more frequent. It's not typically diarrhea, it's just more frequent bowel movement. Menses, on the other hand, tend to be less frequent and less heavy in women with hyperthyroidism. Weight loss is one of the hallmarks of this disease because you are basically hypermetabolic. So despite eating more and increased appetite, the patient would be losing weight. Oops. So to treat Graves' disease, typically we use beta blockers to improve the symptoms of hyperthyroidism, but also we try to tackle the thyroid gland itself. We're trying to stop the production of new thyroid hormone by the gland. And that can be achieved using pills like methimazole or something called radioactive iodine ablation, where you actually take some radioactive iodine that's concentrated in the gland and destroys the thyroid gland. Or we can resort to surgery. Sometimes methimazole is a little of a problem in patients with liver disease because methimazole itself can cause some liver injury in rare instances, however. So the choice of the therapy really depends on the degree of hyperthyroidism and the clinical scenario where the patient is in. And that really should involve a discussion between the clinician and the patients on what's the best way to tackle this problem. I have to mention glucocorticoids, steroid, and prednisone, really, when they're used for autoimmune hepatitis, typically also ameliorate Graves' hyperthyroidism significantly. So this might be, use of prednisone may mask Graves' disease, and whenever prednisone is stopped, maybe the Graves' disease will flare. Sometimes Graves' disease remits or goes into remission on its own without any intervention. Smoking definitely exacerbates the eye symptoms we see in Graves' disease, and it's strongly discouraged. On the other hand, the opposite end of the spectrum, when there is autoimmune inflammation of the thyroid that can lead actually to hypothyroidism, that we refer to this disorder as Hashimoto's disease. It's the most common reason why people in the general population take thyroid hormone and have thyroid gland failure. It's definitely more common in women than in men. So the chronic autoimmune process may sometimes cause a little transient hyperthyroidism, but ultimately will lead to hypothyroidism, where there's a need to treat with thyroid hormone replacement. Most of the time, this Hashimoto's disease is diagnosed at the end of the disease process where the patient is already hypothyroid. Sometimes patients with Hashimoto's disease present with a goiter, an enlargement of the gland, but most of the time actually the gland is atrophic or small, so it doesn't cause symptoms locally. Symptoms of hypothyroidism, they're kind of like the opposite of what we just described about hyperthyroidism. Hypothyroid patients typically present with feeling too cold. They're intolerant to cold. They have some hair loss, very dry skin. They may be too sleepy, too tired most of the time. Despite being anorexic and not really eating that much, they gain weight. The face might be puffy or swollen. The eyelids typically get some edema in them. Periods in hypothyroidism, instead of like the opposite of what happened in hyperthyroidism, become here more heavy. Constipation is a frequent symptom of hypothyroidism. And as opposed to hyperthyroidism, people who are hypothyroid have low heart rate and usually even have low body temperature. So the treatment of this disease is typically with thyroid hormone replacement. And I would like just to mention a few points. If you happen to be on thyroid hormone therapy, it's really important to do a few steps to optimize the absorption of that thyroid hormone in the gut and to decrease the fluctuation of thyroid hormone levels in the blood. So it's advisable to take levothyroxine and the various forms of levothyroxine on an empty stomach, and to avoid taking it at the same time while you're taking your calcium pill, your iron pill, or your multivitamin, as these medications will bind to the thyroid hormone and delay the absorption or impair the absorption from the gut. It's also important when you're taking your thyroid hormone to take it daily and be compliant with it, and I would advise using a pill box to remember to take it every day. I would also advise, if you're being prescribed thyroid hormone, to stick with the same brand and do not change from one brand to the other, as there is some variation in the dosing from one brand to the other. Moving on to talking about bone health in patients with autoimmune hepatitis. That is relevant because a lot of patients with autoimmune hepatitis are treated with steroid. And steroid-induced osteoporosis is one of the adverse events that could happen. Osteoporosis can be a silent disease, painless. you don't know about it until you're tested for it. But sometimes it can also present with back pain because of a vertebral fracture with minimal trauma. You could be just walking or bending or carrying just a little weight, and you develop acute back pain. So that is sometimes indicative of a compression fracture in the vertebra. Sometimes people just notice that they're getting shorter, or somebody comments on them getting shorter. That's because of some kyphosis and bone loss that occurs in the spine. Sometimes osteoporosis just present with a fracture with minimal trauma. We call it a fragility fracture, a hip, a wrist. So there are some risk factors that affect bone health, and it's relevant in patients with autoimmune hepatitis. Here, there's a picture of bone, like a microscopic picture of bone, normal, and then thinner bone, and then osteoporotic bone. And as you can see, there is less bone mass in the same area there, and make it more prone to fractures. Inflammation, general inflammation in the system, like what happens in autoimmune hepatitis, is detrimental for bone health. Steroid use, the anti-inflammatory medication, is also significantly not good for your bones, especially when it's used on high dose for a long time. Smoking and alcohol are toxins to the bone, and their use is strongly discouraged. Family history, that's something you cannot change. If you have a family history of osteoporosis and hip fracture, that's a significant risk factor to developing osteoporosis. Calcium and vitamin D intake is very important for your bone, and we'll talk a little bit about it, and more so when steroid is used, as steroid impair the absorption of calcium from your gut. Inactivity, it could be just sedentary lifestyle, or because of deconditioning or being bedridden for a long time. That's not a good thing for your bone. Your bone need the weight bearing, need that stimulus to continue to be healthy. Weakness or muscle myopathy, like it's a disease of the muscle that could develop from high-dose steroid actually. Both of this can lead to more propensity to fall, and the more you fall, the more likely you will break a bone. Also hyperthyroidism, which as we discussed earlier, which can be present in autoimmune hepatitis, can also lead to bone loss and more risk for osteoporosis. Just briefly mentioning about calcium intake, maybe that was discussed earlier this morning, but calcium intake is very important for your bone, more so when steroids are used. Most experts would recommend about 1,000 to 1,200 milligram per day of calcium. That could be achieved by eating a healthy diet rich in calcium, or can be supplemented with calcium supplements. So I just put a picture here of the most common, the food that's pretty rich in calcium, and it's mostly dairy product. And sometimes you can just, orange juice can be usually fortified with calcium, or cereal can be fortified with calcium. And some green vegetables are usually rich in calcium. But if for some reason you're restricting dairy from your diet because of lactose intolerance, or just you don't like dairy product, make sure you get about 1,000 to 1,200 milligram of calcium using supplements. Vitamin D is very important because vitamin D is important for calcium absorption and for bone building using the calcium. Vitamin D sources, mostly it's sunlight. If you live in Florida, you get plenty of that, but in the wintertime in Indiana, you may not get enough sunlight to make vitamin D. Food that's usually pretty rich in vitamin D is usually fish, egg, and cheese, and some other fortified food like cereal and orange juice. If there's a concern for vitamin D deficiency or lack of vitamin D, it can be easily measured in the blood. And your physician can prescribe higher doses of vitamin D. But the typical vitamin D dose that most people should be taking, especially when they're on steroid, is about 800 to 1,000 international unit daily, and that can be found over the counter. Another very important thing for your bone health, like as I said, inactivity is not good for your bones. So you need to be active. The exercises that are usually recommended for people who are prone to osteoporosis or bone loss are weight-bearing exercises and core strengthening. And I would highly encourage the patients to be involved with a group of people, spouse, partner, kids, exercise together. It makes it more fun and it's more sustainable. But you should not be waiting for the perfect condition to exercise. I'm not saying you should go running when it's icy and snowy outside. Actually, I would discourage that for people who are taking steroid and are prone to fracture. That's a high-risk behavior. But do not wait for perfect condition to exercise. Prevention, you do your part, you take enough calcium and vitamin D, you exercise, you don't smoke, you don't drink alcohol, but your doctor can also help prevent steroid-induced bone loss or osteoporosis. It's highly encouraged to get a DEXA scan or a baseline bone density test when somebody is being started on steroid. And DEXA scan is a very easy procedure. It's pretty similar to a CAT scan. And your physician can prescribe, depending on your bone density result, they can decide to prescribe medication to prevent fracture, or if you already had a fracture, to prevent a second fracture. Typically, it's recommended if prednisone is being used at a dose higher than 7.5 milligram per day for an expected duration of more than 3 months. Typically, we would be recommending an anti-resorptive drug, and I will mention them, something to prevent osteoporosis. That's clear-cut in postmenopausal women or men older than 50. If you're younger than that, most people may consider waiting and see if there is significant bone loss with steroid use. That's kind of a controversial point, though. Some of the medication you might be familiar with that used to treat or prevent osteoporosis are something called bisphosphonate, commonly alendronate and risedronate. These are the pill form that you take once a week. Sometimes we resort to infusions with zoledronic acid, and there's actually some injection that you could take, like teriparatide. It's a daily injection, and that's been also approved to prevent bone loss with steroid. Some other drugs are also available. Moving on to talking about diabetes and glucose in patients with autoimmune hepatitis. As I mentioned, type 1 diabetes, the autoimmune form of diabetes, can be associated with autoimmune hepatitis. This is related to the destruction of insulin-producing islet cell in the pancreas being that gland next to the stomach and the intestines. This type 1 diabetes usually occur at a young age, and in that condition, there's an urgent need to start insulin therapy. Now, more commonly, type 2 diabetes happens to also be present in patients with autoimmune hepatitis, and that's usually more related to the fact that the patient is overweight or obese, and more commonly with family history of type 2 diabetes. Type 2 diabetes is usually treated with pills at the initial stages, but insulin will, may be needed at a later stage. There's something called steroid-induced diabetes. So just because you started on high-dose steroids for the autoimmune hepatitis, diabetes may develop, and typically that resolves when steroids are stopped. I just want you to be aware of the symptoms of diabetes so you recognize them in case this happens. So diabetes usually presents with increased thirst, excessive drinking and urination, blurry vision, weight loss, and in women, frequent vaginal infection. And fatigue is another symptom too. Rarely, acute onset, abrupt onset of nausea, vomiting, and abdominal pain could be the symptoms of what we call diabetic ketoacidosis, and that's more commonly seen in patients with type 1, the autoimmune type of diabetes. So what I suggest when you're started on steroid and you happen to have diabetes predating that, it's really important to monitor your blood sugar frequently, to really try to be strict regarding following a diabetic diet, and be kind of expecting that diabetes medication may need to be titrated, insulin may need to be started when high-dose steroids are being used. And it's important to check your blood sugar not just in the morning, but also in the evening. With steroids, usually blood sugar is elevated more so in the evening. The last kind of point I would like to make for people who are being treated with high-dose steroids, you know, the adrenal gland are these tiny glands that are located just superior to the both kidneys. These glands usually make various hormones, but most importantly, they make cortisol, which is actually like prednisone. It's a steroid that are, you know, they're stress hormone. These are very important hormones in the body. But when you're being treated with prednisone exogenously, you're getting a high-dose prednisone, the adrenal gland kind of quit working, and they don't need, because they don't need to make cortisol because it's being received from the outside, and they quit working. And while you're on prednisone prescription, you're fine. But when that's gonna be stopped, there might be a problem or a delay from the adrenal gland recovering their function. So we highly advise, after a long, prolonged, high-dose prednisone use, to have a gradual taper of the steroid dose and be tuned to the symptoms of adrenal insufficiency or cortisol deficiency. And the symptoms of adrenal failure or low cortisol are usually fatigue, weight loss, dizziness, especially in the morning, nausea and vomiting, and low blood pressure. So if steroid is stopped and a few days later you're having these symptoms, you just need to be aware. Typically, your physician should be, you know, warning you about these symptoms when prednisone is stopped. So some take-home points. I just would like to remind you to recognize some of the symptoms that are related to thyroid disease: a goiter, an enlarged thyroid, dramatic weight changes without, you know, concomitant increase in food intake or, you know, weight gain despite not eating too much, heat and cold intolerance. Just think about thyroid, and these can be easily tested. I want to remind you about the healthy habits to prevent bone loss while you're being treated with steroids. Be wary of good calcium and vitamin D intake through your diet. Avoid the toxins, smoking, and excess alcohol. Exercise, weight-bearing exercise, and core strengthening. So if you fall, you can, you know, have a good core to balance. Fall prevention, and sometimes considering preventive medication. Should recognize symptoms of new onset diabetes, excessive thirst, excessive drinking, and urination. Glucose monitoring if you're being treated with steroids and you already have diabetes, and, you know, expect some intensification of diabetes medication. And I want you to remember the symptoms of adrenal insufficiency when prednisone is stopped. And that's it. I'll take some questions if.
Sure, we may have time for just a few questions. We actually are going to forego the Q&A at the very end just based on time constraints. So if there are any questions, I can bring the microphone to you.
What is an appropriate time span when weaning from prednisone?
Appropriate time span. I mean,
Yeah.
typically, I mean, if you've been treated with autoimmune hepatitis, typically that's a pretty high dose. But when you get to prednisone 5 or 7 milligram, or, you know, 5 and 10 milligram, kind of that range, then this is when it needs to slow down, because 5 milligram prednisone is what your body normally makes. So when you go below that dose, this is when you start running into trouble. So if 5 milligram things are typically you do okay on it, but when it's decreased further, then this is when you need to be wary. And it can be reduced slowly then, like 4 milligram for a few weeks, 3 milligrams, while letting your adrenal gland kind of recover.
So maybe time for one more question for Dr. Lteif.
The hyper versus the testing is the same, or is it different?
I think I skipped that slide by mistake. The testing, the hormones we measure for hypo and hyperthyroidism are the same, but the TSH, that's the typical test we do, is usually low in hyperthyroidism and high in hypothyroidism. I'm sure your physician will also be checking T4, which is a thyroid hormone level, and some antibodies can also help diagnose hyper and hypothyroidism, like the etiology. They're, the antibodies that are frequently found in these disorder. But the testing the same, the result will be the opposite.
Thank you, Dr. Lteif. Appreciate
Okay,
it.
thanks.